Case number 14 is a focal asymmetry seen on the upper outer region on a postmenopausal patient with essentially baseline screening mammogram. And here on the spot magnification view, you could see the focal asymmetry with fine pleomorphic calcification, which are BIRATS 4. And when we did the biopsy, it was IDC with DCIS. So the teaching point here is that when you have a focal asymmetry with associated calcifications, even if it is on a baseline study, is worrisome and should prompt biopsy. So in summary, when you have calcifications on screening mammography, it's only BIRAT 0 or BIRATS 2, BIRAT 0 with magnification views if it is a baseline calcification, or if it is new or increasing from the prior screening, or if it's BIRATS 2 and if it's a typically benign calcifications. And again, calcifications on diagnostic mammogram, you always want to get magnification CC and 90 lateral view, and also tangential view for skin calc workup. Again, it's BIRATS 2 if it's typically benign, and you can assign BIRATS 3 calcification if it is round or punctate calcification in a grouped distribution on a baseline mammogram, and it's BIRATS 4 if there's any suspicious distribution or morphology. Thanks, and I will, that ends my case reviews, and I'm open to any questions. Thank you. Case number 13 is a 34-year-old pregnant female with a palpable mass. What is your recommendation based on this ultrasound? Okay, perfect. So everybody, it's like 100% got the correct answer. Here you could see it is a mass with indistinct margin and echogenic foci. Obviously, because the patient is pregnant, we don't recommend contrast enhanced MRI because all the gadolinium based contrast agents are classified as category C. And again, surgical consult is not appropriate when you have an ultrasound finding that can be biopsied with high probability of success. And the pathology was a DCIS with a microinvasion. In this case, in this particular case, we ended up doing the mammo before the biopsy. The patient was 36 weeks pregnant, and she insisted us to do the mammo before she delivered. So here you could see fine pleomorphic calcifications in grouped distribution correlating to the palpable area, which we saw on ultrasound as well. So just a few words about pregnancy-associated breast cancer. It is the cancer that occurs during pregnancy or within the first year of childbirth. Ultrasound is the initial modality of choice. You can do mammography if there's a high index of suspicion, before the biopsy, or if you definitely want to do mammography after you got the diagnosis of breast cancer to determine the extent of disease in the ipsilateral breast and contralateral breast. And a few words about the mammography is that the estimated dose to the uterus is less than 0.03 micrograms, which is exponentially less than 50 milligram threshold. So it is, and when the lead apron actually shielding decreases the dose to uterus up to 50%. As far as the core biopsy is concerned, that local anesthesia with lidocaine has no known harmful fetal effects. And when the patient is lactating, there is a rare complication called milk fistula, where it's a tract between the skin and the duct, and the milk will flow through the path of least resistance and out through the skin instead of the nipple. So we minimize it by nursing or pumping before we do the neonatal biopsy, and encourage them to continue pumping even after the biopsy. Majority of the time it spontaneously regress, but if it continues to leak through that skin tract, then the patient have to stop nursing from that breast. Okay, case number 12 is just screening mammogram. I'm going to show you close-up view, and I'm also going to show that patient and a different patient, again, same or same process. So here, what is the most appropriate BI-RADS assessment? And in this case, it's BI-RADS 2, because you see diffuse bilateral round calcifications. But this is a companion case where you have multiple groups of bilateral benign milk of calcium. You could see it's like smudgy on the CC view, and you could see layering on the magnification 9D view. But you have to make sure all of the groups have similar benign morphology. So here you could see there is one group that had different morphology, which was fine pleomorphic calcification, and not surprisingly was DCIS. Case 11 is new calcification seen on screening mammogram. It's just a close-up view, not a mag view, close-up view, so a 2D CC and MLO views and TOMO views are shown here. So based on the calcification zone, what is the most appropriate BI-RADS assessment? Okay, great. So this is actually skin calcification. So the correct answer would be BI-RADS to return to screening. So a few note about skin calcification. So when you have tomo, so here you could see the tomo slices. If it is on the first slice, first few slices, I should say, then the chances of this being skin calc is pretty high. Why do I say first few slices? Because more slices are added to the compression paddle side, and on hologic, it's always on the head and on the medial side. So it's like head and the medial side. So what it means is that the first few slices on, this is just for the hologic, because that's what we use. So I'm not sure if different manufacturers might have different, but the first few slices are not breast, it's just adding on to that compression paddle side. So the skin on the skin actually starts few slices later. So whereas on the feet, like right here, this is actually the skin. So that's why I say that skin calc can be either on the first slice for sure, or it can be on the first few slices if it is on the compression paddle side. So teaching point about skin calcs is that usually they are lucent centered, and they're located along the inframammary fold, cleavage, axilla, or nipple. There is a sign called tattoo sign that is described in the literature, where the skin calcs can look exactly this. If it's a skin calc, it can look exactly the same configuration on both CC and oblique view. So it's pretty much like identical. When it's on CC and oblique view, then you have a high probability or high chance that these are skin calcs. But if you don't have classic skin calcifications, which are like lucent centered and no tomosynthesis, then you want to do a skin calc to make sure it is dermal. So here's a case where you see there's indeterminate calcification. On CC view, it was central posterior, and on the 9D view was inferior. So probably around like 6 o'clock-ish on on the CC and 9D view, and obviously it was not on the skin itself. So, but our thing was like it could be potentially could be skin calcifications. So, how do you do a skin calc workup? So we all a lot of us know that we put a grid in either CC view or 9D view. The question is, do you this if it is a 6 o'clock lesion, or sorry, a 6 o'clock calcification, do you put the grid in CC view or do you put a grid in 9D view? From my experience, before the tomosynthesis, I usually place the grid on the view that is shortest from the distance. So I tell my fellows and residents, it's similar to how you do the needle looks. If you do needle looks, you always want to do the shortest distance from the skin. So in other words, if it is let's say if it is at 6 o'clock, I would put them on a CC position, and I would put that alphanumeric grid on the inferior part of the breast on the CC view, and then you mark those calcifications with BB, and then you do a tangential view, and in this case you could see that the tangential view confirms that these are within the skin itself. So why do you do all of these? Because if these calcifications can be proven to be skin, then they require no additional workup or even surveillance, and patient can return back to screening. This is a case number 10 where a 70-year-old was called back from screening. So on the spot images, you could see there's a solitary mass with indistinct margins. You see the margins are indistinct here and here, and you could see there's coarse calcifications. Again, all of these worrisome features should prompt biopsy, and in this case, it was invasive cancer with metaplastic features. I just want to show you a companion case with mass with calcification. Here you see a 60-year-old with bilateral palpable masses. Here, in contrast to the prior case that I shown, there are multiple oval masses with circumscribed margin, and some of this containing coarse pop-like calcifications. These are involuting fibroadenomas, and it's BIRADS2. So here you could see there's different phases of involuting fibroadenoma. So here you just see the mass, and then here you could see the mass. It starts with peripheral calcification, and in the final phase, you just see the popcorn calcification and you don't see the underlying mass. Again, this, when you have multiple circumscribed masses, you wanna, it's usually a sign of benignity, whereas when I show you back on the prior study, always beware of solitary mass with a non-circumscribed margin associated with calcifications. Okay, so moving on to question number 9. There's new calcification in the post-lumpectomy oncoplastic reduction. What is the appropriate BIRADS assessment on these on this calcification? So this is BIRADS2 benign finding. What we see is a rim calcification with associated fat, and this is classic for fat necrosis. Usually fat necrosis occurs in the first 2 years of surgery or radiation. If it is like, let's say 5-6 years, unless it's a very classic fat necrosis calcification, you should have a low threshold to biopsy those. This is a companion case. Recently, it was a screening callback from a screening. This was right at the prior surgical site. So here you could see, if I show you the other thing, like here you could see there is a little bit of, hold on one second. There is a little bit of fat you could see inside. And so my fellow was telling me that this could be fat necrosis. But when you think carefully, when you look at it carefully, that's what I'm gonna do. Here you could see there's a new density suggestive of a mass surrounding this fat. And by the way, this distortion it's post-surgical. It's always been there, so it was a post-surgical distortion. But there's this new density, and you could see these amorphous calcification extending anteriorly towards the nipple. Um, so when you have both of these worrisome features, you should that should prompt biopsy, especially if you have calcs that are ductal and extending to the nipple. With the exception of the large rod-like calcification, make sure you have low threshold to biopsy. And in this case, we biopsied and it was invasive ductal carcinoma with DCIS. Case number 8 is a 45-year-old. So his patient is here for stereotactic biopsy of these calcifications. So the specimen radiograph, I don't know how well you can see it on the specimen radiograph while performing the stereotactic biopsy is shown, which actually does not show any calcifications. So the question is, what is the best next step to do? Okay. Great. So majority voted for C, which is actually the correct answer. You want to obtain more samples. So what you hear is like, you definitely see a group of pleomorphic calcifications, right? And we see on the specimen radiograph, there are no calcifications noted. And if you look at it, these are like about 5 to 6 tiny samples. So if this occurs, we need to do additional samples while the patient is still on the stereotactic table. Either you can retarget the calcifications, or you use the directional capabilities of the vacuum assisted needle. What I mean is, like, if the calcifications are on the inferior part of the needle, you can actually move your chamber towards the inferior part and suck those calcifications, suck those calcifications that way. Again, after you do that, you need to do an additional specimen radiograph to make sure that the calcium is within the specimen. What happens is that if you don't have representative calcification, then the possibility of a false negative biopsy increases significantly. So therefore, you don't want to put a clip at this point, and you want to get more coarse instead. The follow-up diagnostic mammogram in 6 months is not appropriate in case of insufficient biopsy. And surgical consult is not recommended when there is a high probability of success if we do more sampling. Case number 7 is a 55-year-old presents with this new left nipple change. And this unilateral nipple change is concerning for a contact dermatitis, melanoma, nipple adenoma, or Paget's. Great. So it is a classic for Paget's disease, where you see it's crusty eczema on the nipple, whereas dermatitis, it's usually both nipple and areola. Nipple adenomas is usually a lump on the nipple rather than more like crusty eczematous changes. So the next step would be to do a diagnostic mammogram. So on the diagnostic mammogram, what is the best BI-RADS descriptor for these calcifications? The answer would be fine linear branching in segmental distribution. Here you could see that these calcifications, this is the nipple. I know it's an old picture, but you could see these calcifications are extending to the nipple itself. So again, the answer would be fine linear branching in segmental distribution, and this is a BI-RADS 5 category. And what is the next best step? In this case, the stereotactic biopsy would be the next best step. Surgical consult is not appropriate at this point when we can do a needle biopsy successfully. It's obviously not a BIRATS 3, it's almost a BIRATS 5 lesion. And so B and D is not approved, it's not the correct answers. And in this case, the biopsy yielded high-grade DCIS. So a few words about Paget's. It's a rare cancer. It's 1 to 3% of breast cancers, but about 80 to 90% are associated with underlying DCIS or invasive cancer. Clinically, I wanted you guys to be aware of that for Paget's, you see the changes in the nipple first and then the areola, whereas I see a lot of patients that has the eczema. Eczema usually involves both areola and the nipple, whereas Paget's is always, you can always ask them, was it just on the nipple first and then it later on went into areola? Then you want to think about Paget's at that time. Again, they can present with nipple retraction and bloody nipple discharge. So the treatment is mastectomy versus breast conservation with complete resection of the nipple areola complex followed by the radiation therapy. So here's a companion case where you see smooth, thick rod like calcification, which are more dense. Some of it can have like tapered and these are secretory calcifications. Remember, both DCIS and secretory calcifications can be ductal in distribution, but but in contrast, you could see the calcifications associated with DCIS is more fine. It's like less than 0.5 millimeters. And the secretory calcification is usually seen in older women, and the pathology is duct ectasia. So the next question is, which BIRAD description of calcifications has highest rate of malignancy? And okay, great. So fine linear and linear branching calcifications have the highest rate for malignancy. So some of the numbers is, it's about, this is just for the morphology, not including the, this is not including the distribution. So it's about like 80% in fine linear or linear branching calcifications. And it's about 40 to 50% in fine pleomorphic calcification, about 25% in amorphous, and about 13% in coarse heterogeneous calcification. So you could see the fine linear and linear branching calcification is the most suspicious out of all the suspicious calcifications, and the coarse heterogeneous calcification is the least suspicious. As far as the positive predictive value for the distribution, the regional and grouped is about 30%, and the linear is about 50%, and segmental is about 80% positive predictive value for malignancy. Again, as far as the distribution is concerned, the segmental would be the has the highest rate for malignancy. Case 6 is a 60-year-old screening callback. What you see is amorphous calcifications. These are calcifications which are difficult to see, which means they are hazy on both CC and 90-degree views. So in contrast to milk of calcium, which can be smudgy on CC view and kind of hard to see on CC view, but layers on the 90 view, amorphous calcifications are difficult to see on both CC and 90 view. In other words, you cannot define a particular shape to these calcifications. So these, in this case, it was a grouped amorphous calcification, which is also assigned BIRADS 4. So the teaching point for amorphous calcifications, as I said, it's like hazy on both CC and 9D view. The distribution is important, just like the coarse heterogeneous calcification. If it is diffuse and bilateral, it becomes a BI-RADS 2. If it is grouped, segmental, or linear, it becomes BI-RADS 4. And the positive predictive value is around 25%. So case 5 is a 55-year-old screening callback. We don't have any prior images. So what is the BI-RADS assessment and descriptor for these calcifications? So the answer to this question is find linear calcifications. Here you could see there are fine linear calcifications, but it's not at the periphery of a tubular structure. Excuse me. It's not at the periphery of a tubular structure. So this becomes a BI-RADS 4 lesion. So the same thing, if you look at it, you could see these calcifications are actually necrosis filling the lumen of the duct. Here, the big one right here, you could see that these are necrosis filling the lumen of the duct. The bottom one is a picture from Tabar that you could see eventually these calcifications that I showed could eventually fill the entire duct. And Dr. Tabar calls it as snake skin calcifications. A companion case here is a new calcification seen on screening mammography, shows linear calcification. And there is a suggestion that it's part of a nearby tubular structure, again, at the periphery of the tubular structure, and thought to be evolving vascular calcifications. And on the follow-up exam, you could see the classic tram track appearance of the vascular calcifications. So case number 4 is a 50-year-old with new calcifications seen on the screening mammogram. So magnification view is provided here. And the question is, what is the best BI-RADS assessment and descriptor for these calcifications? Great. So the answer to this question is coarse heterogeneous calcification in grouped distribution. So when we talk about the distributions, I know we talked about regional, segmental, and grouped. In terms of the linear distribution, it means that it's a straight line, calcifications within a straight line. So it is linear distribution. Why is it not a regional distribution? It's because regional is more than 2 centimeters in more than 2 centimeters. And here you could see, I magged it up, but it's less than, it's definitely less than 1 centimeter. So it is actually in a grouped distribution. And you could see more coarser calcification here rather than more punctate calcifications. So the pathology yielded atypical ductal hyperplasia with associated calcification. Is this concordant, and what is the next best step? It is concordant, and the best next step will be the surgical consult. There are controversy regarding the management of high breast lesions on core biopsy. First, I would say that you need to do a careful RAD path review. If it is concordant, and if you don't have any high risk conferences at your institution, I recommend all of the high risk lesions that we diagnose on core needle biopsy to go and see a breast surgeon. So why surgical consult for atypical ductal hyperplasia? So the upgrade rate from ADH on the core biopsy to either DCIS or invasive cancer on the surgical excision is reported to be anywhere from 15 to 30%. Also, ADH is a precursor lesion, which means that women with ADH are 4 to 5 times more likely to develop breast cancer than those without. And therefore, some of these women are offered chemoprevention, such as tamoxifen, to reduce the risk of future breast cancer. Here is a companion case where a 60-year-old with bilateral calcification seen on screening mammogram. Here you could see multiple bilateral groups of coarse heterogeneous calcifications, and obviously that is BIRATS2. Here you could see coarse heterogeneous calcification, and it's BIRATS2. So the teaching point of the coarse heterogeneous calcifications are, it is more conspicuous, like you could see those calcification, but it can be irregular in shape, and it's usually more finer than the DCIS, more coarser than the DCIS calcifications, which is less than 0.5 millimeters. The distribution is important. So if it is diffuse and bilateral, then it becomes a BIRATS2. But if it is grouped, segmental or linear, then it becomes BIRATS4. So the positive predictive value for malignancy is about 13% for the coarse heterogeneous calcifications. Case 3 is a 30-year-old with a palpable area. What is the best BIRAT descriptor / assessment for these calcifications? Great. So here, all of you got it right. It's a case of fine pleomorphic calcifications. What does pleomorphic calcification means? It's a different shape, size, and density overlying the pectoralis muscle, extending all the way to the subareolar region, which spanned about 6 centimeters. So let's go over some of the distribution of calcification. Segmental means it's a triangle that's pointing towards the nipple. So here you could see it's a segmental distribution. It's a triangle that's pointing, which is a suspicious distribution. Grouped means when you have a minimum of 5 calcifications within 1 centimeter, or you can have a larger number of calcifications within 2 centimeters of each other. Regional distribution is when you have greater than 2 centimeters, but not in a segmental or linear distribution. Obviously, diffuse is entire breast. So the pathology yielded DCIS, and given the extent of the calcification and the dense breast, MRI was performed prior to the surgical treatment. One is to evaluate the relationship of the tumor to the fascia and to see if there's any pectoralis muscle invasion, and obviously for any multicentric or contralateral disease in this dense breast premenopausal patient. So we did an MRI. You could see non-mass enhancement in segmental distribution extending to the fascia, but there was no pectoralis invasion, which was confirmed on her mastectomy. So the next question is like, which histologic feature distinguished DCIS from invasive ductal carcinoma? So the answer to that is the integrity of the basement membrane. So DCIS has intact layer of basement membrane and myoepithelial cells, whereas invasive cancer is invaded through that basement membrane. So the degree of nuclear pleomorphism actually determines the grade of the breast cancer. So nuclear pleomorphism means how much does the tumor cells vary in size and shape compared to normal breast epithelial cells. Obviously, if it varies a lot, it becomes grade 3 or high grade cancer. And if it's close to the normal epithelial cells, then it becomes a low grade or grade 1 cancer. The number of mitosis, which is how fast it is proliferating, also determines the grade of the cancer. So if the mitotic activity is low, then it's considered grade 1 cancer. And obviously, if the mitotic activity is high, then it's considered a grade 3 cancer. For the D, the presence and absence of microcalcifications. The calcifications can be seen with DCIS and invasive cancer. And on the other hand, DCIS can be non-calcified, just like invasive ductal carcinoma can be non-calcified as well. Second case is a 40-year-old female with calcification seen on baseline screening mammogram. How would you describe these calcifications? Great. So the answer to this is round calcifications. Here you could see pretty round calcification in a grouped distribution. So the next question would be, what would be the next step in managing this patient? So a single group of round or punctate calcifications can be assigned as BI-RADS 3 after you work up with the magnification view, given it's a baseline study. So the answer to this question is BI-RADS 3, which is short-term mammographic follow-up. Again, it is not BI-RADS 0. Additional evaluation with MRI is not indicated for calcification workup of round calcification. It's not BI-RADS 2 return to screening because it is a solitary group rather than bilateral and diffuse. So you don't want to return them to screening. And it's not BI-RADS 4 because it is on a baseline study and it's grouped round calcifications. In this case, you could see the magnification CC follow-up 3 years later. This has been stable for 3 years. So this is a companion case, a 42-year-old with calcification seen on baseline screening mammogram. You could see a group of punctate and round calcification in grouped distribution. Since it was a baseline study, BI-RADS 3 was assigned. But when you look at the follow-up magnification view in 1 year, you could see there's a new mass now associated with the calcification. So obviously this BI-RADS 3 became BI-RADS 4, and it was pathology yielded invasive ductal carcinoma with DCIS. So the teaching point for group of round or punctate calcification is that if you have a solitary group of round/punctate calcification on a baseline study, you can be assigned BI-RADS 3 after you work up with magnification view. If those round calcifications are diffuse and bilateral, it becomes BI-RADS 2. But biopsy is needed when these round or punctate calcification is in a linear or segmental distribution, or if it is new or increasing, or it's adjacent to a known cancer. Again, biopsy is needed on the follow-up exam if there's any development of any suspicious morphology or suspicious mass. Here you could see how the round or punctate calcification can be BI-RADS 2, BI-RADS 3, or BI-RADS 4, depending upon the different scenarios. Good afternoon. My name is Jean Kunjman. Today we're going to talk about the breast calcifications and how do you manage breast calcifications. I don't have any disclosures. So case 1 is a 45-year-old called back from screening for new regional calcifications. So magnification CC and 90-degree views are provided. So the question is, what is the appropriate BI-RADS assessment for these new regional calcifications? Great. So here you see smudgy, hard to see calcifications on the CC view, and it changes shapes to curvilinear or crescent shape on MAG 90 view. These calcifications, as you can see, are conforming to the inferior portion of the microcyst, and these are milk of calcium, and it's typically benign. So the answer for the question number 1 is BI-RADS 2, benign finding. This is almost classic for milk of calcium. So it would not be considered BI-RADS 3, where it's probably benign. And it is definitely not BI-RADS 4. As I said, it's almost classic for milk of calcium. And BI-RADS 0 is surgical consult. We usually don't do surgical consult for regional calcifications seen on mammography. So here you could see how the calcifications are smudgy on CC view, but it's layering on the 9D view, and it is milk of calcium. If you don't have the classic milk of calcium, and if you're considering the possibility of milk of calcium, you can use a tip called delayed magnification view, where you put the patient under light compression on the 90-degree view for about 3 to 4 minutes, and then you take the magnification 90 view again. What it does is, like, this gives time for these calcifications to sediment within those microcysts, and therefore you can see more calcifications layering on the delayed magnification view. So here's a case where DCIS can look like milk of calcium. But when you look at the mag views closely, you could see the cup shape is seen on the CC view rather than on 90 view, and there's no change in shape between the CC and the 90 view. The second thing is it's linear or straight in distribution, so both of these worrisome features should prompt biopsy.